last topic and everybody is in hurry to go home. I hope I won't bore you. So my topic is common office emergency procedures in OPD practice. So in day-to-day life, we dealt with many emergencies while sitting in the OPD like dehydration, shock, anaphylaxis. So all these procedures requires management, not a procedure. So I am not going to take it because you are well aware with the management and etiology of this topic. So I am going to deal with the procedures, OPD emergencies, which requires procedures to be done to manage. So first I would like to disclose that it is useful for the doctors who are practicing at periphery in resource limited setup where the super specialty services are not available easily, as well as we as an individual practitioner we should know all these procedures. So this procedure aims at acute pain relieving or problem solving. Another is second aim is organ saving or tissue saving. So you know the avulsion of permanent tooth is a dental emergency and you have to restore that permanent tooth because reimplantation of that teeth is possible if you conserve it in proper condition. And third is first attempt before availability or arrival at specialty services. Yesterday we have seen the detorsion of testis is very important because it has very few hours of life, because if you detort it successfully in case of torsion testis within 6 hours you can save that testis. So these are some tricky procedures. Even the wrong manipulation can worsen the situations. So which are these procedures? तर मला आठवते मी पेरिफेरीला वर्क करत होते त्यावेळेस एक फिमेल आलेली तिच्या पायामध्ये रिंग स्टक झालेली होती, जोडवं फसलेलं होतं आणि टेंडर स्वेलिंग होती. शी वॉज इन एगोनी अँड शी ट्राईड टू इमिडिएट रिलीफ. पण त्यावेळेस मी जे ट्रॅडिशनल प्रोसिजर आहे सोप वॉटर किंवा लुब्रिकंट अप्लाय करून मी काढून बघितलं, ते झालं नाही माझ्या क्षणी. मी तिला शेवटी पेनकिलर दिला आणि ती गेली. सेकंड डेला ती आली त्यावेळेस तिच्या पायात रिंग नव्हती. मग मी म्हटलं तू कसं काढलं, तर मी सोनाराच्या दुकानात गेले आणि त्यांनी ते कट केलं. सो वी शुड नो सच ट्रिक्स टू मॅनेज दिस काइंड ऑफ इमर्जन्सीज. So which are the common emergencies? So this epistaxis, foreign body nose, foreign body ears, Zipper's injury. I know everyone has faced this injury while sitting in the OPD, and I know when the senior pediatricians had started practice in the Latur, the super specialty services are hardly available here. So they know all these procedures because they are the whole and soul to manage these. So we will start with epistaxis and don't go into detail of etiology, and so I will focus on the management purpose only. So mostly in the children, it is from anterior in origin and it is of venous origin and it is recurrent. The most common cause is friable mucosa, dry mucosa. Even the simple blowing or sneezing can cause epistaxis. That's why we are getting that cases mostly in the summer season. And second habit is because of this nose picking. So we know all the procedures. This is direct pressure, it is traditional procedure. Second is topical vasoconstrictor. Third is cauterization and anterior nasal packing. So we'll see one by one. So child should sit comfortably on the parent's lap. His head should be tilted forward so that he should not swallow that trickle blood, because it causes hematemesis or profuse vomiting, bloody vomiting, and that also creates the panic situation. So sustained pressure of at least 10 minutes is required on the anterior cartilaginous portion of nose. And child should allow to breathe through mouth, and he should allow to spit the blood in the kidney tray. As well as we have to apply the cold compresses. So mostly the parents do this at home. When they come, still the bleeding is continued. So what is the reason for not stopping bleeding, stoppage of that bleed? It is inadequate pressure. कारण आपण जेव्हा पॅरेंट्सला सांगतो की तुम्ही अप्लाय करा, किंवा आपण जरी अप्लाय केलं तरी आपण थोड्या वेळाने ते उघडून बघतोच की ब्लीडिंग स्टॉप झालेला आहे की नाही. So sustained pressure is necessary and wrong site of pressure. So if the bleeding is not stopped with such traditional method, we can use such innovative methods to give sustained pressure. That nasal clip is available freely in surgical store as well as in online. It is hardly costing 300 to 400 rupees. You can apply with that. Can we use that clips we routinely use to hang the clothes? No, because that causes very close or hot pressure and that can injure the nasal mucosa. So another innovative method is that wooden spatula, tongue depressor, is readily available with us. we can make a clip by applying sticking to one end, and we can create that nasal clip. So applying nose clip is a simple and effective method of controlling bleeding because of sustained pressure. Second method I have told already, that is a topical vasoconstrictor. So you can apply the mixture of anesthetic as well as vasoconstrictor, that means 0.25 ml of adrenaline undiluted along with like lignocaine 20 ml. You can prepare that solution and soak the cotton swab with that solution and apply on the bleeding point. Third is cauterization. It is either by electrical cautery, if it is available, it is okay. If it is not available, take a Silver X ointment on the nasal bud and earbud and apply it not on the bleeding point but proximal to the bleeding point, because we want to cauterize the bleeding vessels. And third one is, if the bleeding doesn't stop, then the anterior nasal packing. As a pediatrician, we must know the procedure of anterior nasal packing. So for this, we require bayonet forceps. Gauze piece is available readily with us. So we have to lubricate it and keep the anterior to proximal 2 or 3 centimeter outside the nose, and then we have to place it with the help of a forceps by pleating it, and terminal portion we have to keep outside. We have to restore that terminal portion by sticking it to the cheek, and after 12 to 48 hours we can remove it by lubricating with normal saline. So this is a normal procedure. We all know there are ready-made nasal packing packs are available like Hydrocell, Merocell. It is like a simple ice cream sticks or nasal spatula. So when you put it inside the nose, because of hydrostatic nature, they swell and they apply the adequate pressure and they stop the bleeding. So advantage of this ready-made pack is that it has antibacterial property also, and it is easy to remove. So what do's and don'ts we have to follow: use the humidifier, apply Vaseline or gel, use saline solution, and trims the nail to resist that picking habit. Don't flat or recline because it causes trickling or swallowing of the blood. Don't eat warm food. Don't do the vigorous blow, and don't use the aspirin containing aspirin or blood thinners. So another trouble is management of nasal foreign body. So these are when the child develops pincer graft. We get such child while writing, they put the crayon, or while eating they put some organic foreign body like beads or groundnuts. So mostly it is a unilateral or bilateral, mostly right-sided, because most of the children are right-handed. So what we require at OPD: set up the nasal speculum for proper visualization as well as direct light source like headlight we should require, and foreign body removal instrument like hook or alligator forceps. So we can do with direct instrumentation either by second procedure is balloon catheter, suction catheter, or positive pressure. So this is a hook forceps, and another is alligator forceps. So there is enough space in the superior turbinate. You can insert that hook forceps posterior to that foreign body, and you can scoop it out. If this forceps is not available, can you prepare the forceps at your OPD with simple instrument? That paper clip is easily available. So you mold that paper clip in any such shape, and you are creating a blunt end. So there is hardly any injury when you put it. Okay, so you can insert it from superior surface and beyond the foreign body, and you scoop it out. Another is balloon catheter. It is Fogarty catheter, that is the arterial embolization catheter. You can easily use. You push that catheter posterior to the foreign body, and then you inflate it and scoop it out. And another is instrument that is available, hardly costing 700 rupees. It is an Oxena. It is nasal foreign body extractor. So there is some, it is reusable sleeves are there. You have to push beyond the foreign body, and you trigger it, and you can scoop it out. So all this procedure, all this instrument, it requires instrumentation. So it is possible to resist some resistance offered by that child. Child is irritable, and main complication is if you push it, with that instrument, there are chances of aspiration. So the most patient-friendly procedure is, this is positive pressure technique I like most, because the instruments are readily available with us. So it is either by mouth to mouth by parent or with ambu bag. So indications are large occlusive foreign body and acute foreign body. It is less painful, frightening, and doesn't require any instrumentation. So we'll see the procedure. So here what you do, you apply the face mask to the mouth. You close one opposite nostril by finger, and you press the ambu bag. You deflate the ambu bag 2 or 3 times. For this procedure, for getting adequate pressure, you have to put one finger on the pop-up valve. So we'll see this procedure. We have seen with one puff that foreign bodies get removed with one pressure, or 1 or 2 pressure puff may be required. So you can try this procedure before sending to the ENT person. Another is foreign body ear. Same instruments we can use for foreign body ear, but the main indication is completely visualizing foreign body. Contraindications to that is perforation of eardrum or contact of foreign body with tympanic membrane. So button battery, if they instill in the ear, it needs urgent ENT referral, because time sensitive liquefaction necrosis occurs and which causes permanent eardrum damage. So within 2 hours you have to manage these button batteries. What you need for tympanic membrane visualization? You should have direct light source as well as otoscope and some such foreign body removal instruments. So we all know the traditional procedure, that is irrigation. You can suck out the metallic foreign body with suction of 100 to 150 millimeter of pressure. You can again use the paper clip or bent end if it is properly visualized. For super gums, chewing gums, you can use acetone. 1 or 2 drops of acetone you can instill in the ear to dissolve that foreign body. And for live insects, or you can instill oil followed by syringing. So we have already seen such instruments. Another, I am going to describe here the syringing technique. The indication of that syringing, contraindication to syringing is perforation of eardrum and hygroscopic foreign body. You should not remove that with that syringing procedure because it swells. So how do you do? You can use scalp vein to create that cannula. You cut down that scalp needle portion and you attach to the 20 ml syringe. You can use tap water or normal saline at room temperature for syringing. For syringing, you always direct the pressure towards posterior and superior part. This is scooping out the foreign body from nose for ear. And this is a syringing technique, so you can easily remove the wax, dried fungal debris, epithelial debris, or blunt foreign body. Next is eye injuries. So we all know the child usually stand in the front of scooty while driving. So there are chances of getting foreign bodies in the eyes. Again, we have seen many cases of accidental installation of spray or hand sanitizer in the eyes. So chemical injuries we get normally in the OPD practice, as well as accidental exposure of फेविक्विल. जस्ट 2 दिवसापूर्वी जेव्हा मी हे प्रिपेअर करत होते त्याच वेळेस माझ्याकडे एक पेशंट आलेला आणि त्याची आई त्याला इन्फंटला घेऊन आलेली की फोडणीचं तेल तिच्या डोळ्यात उडालेलं आणि त्या कॉर्नियावर पांढरं पांढरं दिसतंय म्हणून. मी तिला रेफर केलं अर्जंटली, बट शी वॉन्टेड टू गिव्ह इमिडिएट सोल्युशन. शी वॉन्ट सम आय ड्रॉप्स. सो आय नो द सिरियसनेस ऑफ दॅट इंजुरी बिकॉज इट कॅन कॉजेस कॉर्नियल डॅमेज. So I called to the, I have given call to the ophthalmologist and I asked the procedure. He tell me the procedure. So we'll see how to manage. So eye pH is 7 to 7.4. Alkaline or acidic solution damages the layer of cornea. So weak acid solutions are better. So our hand sanitizer contains our acidic solution. So even if you manage later on or 2 or 3 hours, it doesn't causes any harm. But alkaline solution, it has very good penetrating power and it damages the cornea by penetrating it within 45 seconds. So you have to manage it immediately. So you don't rub the eyes because if the foreign body is there, they usually lodge in the superior fornix or inferior fornix. So what will happen if you rub? It will come in front of the cornea and damages the cornea. So for preventing that, you give the splash of water over the eyes and put the gauze piece to prevent rubbing of that eye. Then how to see for the, how to visualize the foreign body? For that we should know how to invert the eyelid. So for superior eyelid, you have to keep cotton bud over the upper lid, and you just turn it out. And here you are visualizing the foreign body. You can roll just that back and you can remove that foreign body. And we'll see the eyelid irrigation. First you instill the anesthetic drop. If you don't have litmus paper, whether it is alkaline or acidic solution, you have Eurosticks with you. You can instill it in the inferior fornix and you can see whether it is alkaline or acidic injury. You can do the syringing by applying the IV set. You can use normal saline or ringer lactate solution for doing that syringing. You again instill the local anesthetic drop in case of chemical injury, and then you can apply after syringing. You can check whether it is normalized or not. Just few minutes, it's an important topic. So if fevikwik is instilled, you have to do the superficial debridement of cornea by applying earbud soaked in betadine and saline 4 ml solution. So first you instill lignocaine drop and you do the superficial debridement. So same procedure I have applied for that weight burn of cornea, and after 7 to 8 days that corneal layer get regenerate and you can send that patient to check the visual acuity. So zipper injury we get most of the time. So how to deal with the zipper injury? The key treatment is to avoid further manipulation of zipper. So there are two types of zipper entrampment, either the this foreskin stuck into the runner part or either in teeth part. So you have to cut this median bar, okay, with instrument. I have tried this but I couldn't succeed. It will take time to cut it. So simple procedure is here. If it is stuck, the foreskin is stuck to the proximal part, you have to cut that distal part and you separate it easily. This is torsion testis. So management of torsion testis is diagnosis triad is acute scrotal pain, high riding testis absent, cremasteric reflex. So how to manage it? Only indication if there is a delay in seeking urological consultation and patient is transferred to some other facility which may take time. So detorsion within 4 to 6 hours is needed, and if it takes time, you have to first attempt the manual detorsion. So usually testis turns inward direction. So you have to detort it in outward direction, just like opening a book. For right testis, you have to try it or pull it anti-clockwise, and for left testis, you have to try it clockwise. You may need intravenous conscious sedation like ketamine. So the first sign is relief of pain. Another is paraphimosis. I am not going into detail. Pulled elbow you all know, because there is no patient comes to you with the history of fall on outstretched hand and there is no any obvious swelling or deformity, only pain is there and unable to move the hand, that is the only complaint. So this is a common technique which needs to, common lifting which needs to pulled elbow. So how to manage? You have to do the flexion, you have to hold the hand like shaking position. You have to supinate it first and then flex it. Another technique is hyperpronation. You have to hyperpronate it. We are going to see the video. This is the hyperpronation technique. You have to keep your thumb on the radial head. After successful procedure, you feel the pop-up sound while radius goes into his annular ligament. And this is hyperpronation technique, and another is supination as well as flexion. So during this procedure, patient may feel intense pain. You have to observe for 10 to 15 minutes. You offer painkiller. After 15 minutes, you observe the child. If it is normalized, he is playing, moving the hand, you can send back. If it doesn't reduce, then you can offer the sling. This stuck ring I have already discussed. So this is very simple procedure. तुम्हाला एक दोरा किंवा स्ट्रिंग घ्यायचा आहे जो त्या डिस्टल पार्टला तुम्हाला इन्स्टॉल करायचा आहे बाय युजिंग सम फोर्सेप आणि यू हॅव टू वाइंड अप द प्रॉक्सिमल पार्ट टू compress that swelling completely, and then you unwind with that free part.
Kiran madam, we are already too late.
Okay. So this is slipping of the ring. It is very easy. Okay. Another is how to store the Eval's permanent tooth. The best solution is you have to clean the socket and you kept it in the mouth, and then stabilize it with offering the handkerchief and by asking the patient to clench, and you can directly send the patient to the dentist. If it is not possible, you can carry out that tooth in the milk so that you can increase the half-life from extraorally 20 minutes to 16 minutes till you reach to the dentist. Thank you. So I would like to thank the organizing chairperson Dr. Menderkar sir, organizing secretary Dr. Sabde sir, my HOD as well as organizing secretary Dr. Mundra sir, advisor Dr. Aradwar sir, senior pediatricians, scientific committee head Dr. Kande madam, as well as IIP president Jiten sir and Nitin sir, secretary, to allow me to present this topic in front of you. Thank you.
Thank you, ma'am.